Block simulation 31. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which statement about the coagulation cascade is correct? A physiologist reviews how the body forms a clot through the coagulation cascade and how lab tests probe each arm. Read the command. Which coagulation statement is correct? Intrinsic to XIX TU factor, tissue factor TXINR, common pathway X leads to thrombin, leads to fibrin. The coagulation cascade has two initiating arms that converge. The intrinsic contact pathway involves factors 12 fictus, XI, X, and 8, and is measured by the PTT, partial thromboplastin time, PTT intrinsic. The extrinsic pathway is shorter. TSU factor, released by injured cells, activates factor EVI, and it is measured by the PTT prothrombin time, AINR. PT extrinsic, factor 7. The correct answer is A. Both arms converge on the common pathway at factor X. Activated factor X with factor Vi converts prothrombin 2 to thrombin, which then cleaves fibrinogen into fibrin. Thrombin also activates platelets and factor 13, which cross-links fibrin. This framework drives clinical reasoning. Warfarin lowers vitamin K, factors 2, 7, IX, X prolongs, PTT, common pathway framework is correct. Has the shortest half-life. Heparin potentiates antithrombin against thrombin and XA, prolongs PTT. Hemophilia, AB, 7s, prolong PTT. PHINX, prolong PTT. Common pathway framework is correct. What is the diagnosis, a common cause, and the type of dysfunction? A 25-year-old man develops progressive dyspnea and fatigue a few weeks after a viral illness. Exam shows an S3, bilateral crackles, and pitting edema. Echo shows a dilated left ventricle with globally reduced ejection fraction, esystolic dysfunction. Read the command. Diagnosis, cause, dysfunction type. Post-viral, dilated LV, low EF, S3 edema, dilated cardiomyopathy, viral myocarditis, Coxsackie, systolic dysfunction. This is dilated cardiomyopathy, the most common type of cardiomyopathy. The ventricle dilates and the walls thin, eccentric hypertrophy. Sarcomeres added in series, producing SY systolic, contractile S-function with the reduced H-function with the reduced ejection fraction. The result is a picture of congestive heart failure, dyspnea, an S3 gallop, pulmonary crackles, peripheral edema, and often functional mitral regurgitation from annular stretch. The correct answer is C. The causes are high yield, remembered by ABCCCD, alcohol, beriberi thiamine, Coxsackie B viral myocarditis, cocaine, chagas, and doxorubicin plus peripartum cardiomyopathy, and genetic familial causes. In this young post-viral patient, viral myocarditis classically, Coxsackie viral myocarditis, classically Coxsackie virus B is the likely trigger. Contrast hypertrophic cardiomyopathy, diastolic dysfunction, thick septum and restrictive cardiomyopathy, stiff walls, diastolic dysfunction. Treat the heart failure and the underlying cause. The dilated, low EF, systolic dysfunction cardiomyopathy after viral myocarditis is dilated cardiomyopathy. Which statement about cell cycle regulation is correct? A cell biologist studies the checkpoints and breaks that control the cell cycle and how their loss leads to cancer. Read the command. Which cell cycle statement is correct? PP3CRB tumor suppressors, breaks. Breaks HB holds G1SH binds E2F. PP3 arrests SHAP apoptosis. 2-hit loss leads to cancer. Cyclin. CDK drive forward. The cell cycle is driven forward by cyclin-CDK complexes, cyclin-dependent kinases, and restrained by tumor suppressors at checkpoints. RB retinoblastoma protein guards the critical G1 to S checkpoint in its active hypophosphorylated state. RB binds the transcription factor E2F, holding the cell in G1 and preventing S phase entry. P53 is the guardian of the genome. After DNA damage, it arrests the cycle, inducing P21 to allow repair. and if damage is irreparable, it triggers apoptosis. The correct answer is E. These are tumor suppressors, not oncogenes, so the genetics follow the K-Newton too. Hit hypothesis: both copies alleles must be lost inactivated to remove the break, unlike oncogenes where one activating mutation suffices. Losing just one p53 allele is not enough. The second hit unleashes proliferation. Loss of RB causes retinoblastoma and osteosarcoma. p53 loss is the most common mutation in human cancers, and germline loss causes Li-Fraumeni syndrome. The p53-RB as tumor suppressor breaks with 2-hit loss and cyclin. CDK as the accelerator is correct. Which statement about fetal circulation and its shunts is correct? An embryologist asks how blood is shunted in the fetus and what happens to those shunts at birth. Read the command. Which fetal circulation statement is correct? Ductus venosus, bypass liver. Foramen, ovale ray, leads to LA, bypass lungs. Ductus arteriosus, PA leads to aorta, bypass lungs, close at birth. Fetal circulation uses Th3 shunts to bypass the non-functioning liver and lungs, directing oxygenated placental blood to the body. Oxygenated blood travels from the placenta in the umbilical vein. The ductus venosus shunts most of it past the liver directly into the inferior vena cava. In the heart, the foramen ovale allows blood to pass from the right atrium to the left atrium, bypassing the lungs. And the ductus arteriosus shunts blood from the pulmonary artery to the aorta, again bypassing the high-resistance fetal lungs. The correct answer is A. At birth, the changes reverse the shunts. The first breaths drop pulmonary vascular resistance and raise arterial O2, increase left atrial pressure functionally, closes the foramen ovale, leads to fossa ovalis. The rise in O2 and fall in prostaglandins close. The ductus arteriosus leads to ligamentum arteriosum. Note prostaglandins keep it open, so indomethacin closes a PDA. The ductus venosus becomes the ligamentum venosum. The umbilical vein becomes the ligamentum teres. Umbilical arteries carry deoxygenated blood to the placenta. The ductus venosus foramen ovale ductus arteriosus shunt set closing at birth is correct. What is the diagnosis, the pattern, and key associations? A 40-year-old man with HIV or heroin use develops nephrotic range proteinuria, edema, and hypertension. Biopsy shows essegeminal sclerosis affecting only part of some glomeruli. It is often resistant to steroids. Read the command. Diagnosis, pattern, associations. Nephrotic, segmental sclerosis of some glomeruli. HIV, heroin, steroid resistant, FSGS. This is focal segmental glomerulosclerosis, EFSGS. A. Common cause of nephrotic syndrome in adults. The name describes the histology. The sclerosis is focal, only some glomeruli are affected, segmental, only part of each affected glomerulus is sclerosed. Like other nephrotic diseases, it presents with heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia, often with hypertension and some hematuria. Light microscopy shows the segmental sclerosis. Electron microscopy shows podocyte foot process effacement. The correct answer is B. The associations are high yield. FSGS is classically linked to HIV-associated nephropathy, heroin IV drug use, obesity, and sickle cell disease, and it is the most common cause of nephrotic syndrome in African American and Hispanic adults. Unlike minimal change disease children, steroid-responsive FSGS is frequently steroid-resistant and may progress to chronic kidney disease. The focal and segmental sclerosis nephrotic syndrome associated with HIV and heroin is FSGS. Which statement about free water handling is correct? A renal physiologist studies how the kidney handles free water using the concept of free water clearance. Read the command which free water statement is correct. Free water clearance solute. Free water excreted. High ADH leads to negative. Retain water. No ADH-DI leads to positive lose water. Thick ascending limb generates free water. Free. Water clearance is the volume of pure, solute-free water the kidney excretes per unit time, calculated as urine flow minus the osmolar clearance. The sign tells you what the kidney is doing with water. When ADH is high, the collecting duct becomes water permeable, water is reabsorbed, the urine is concentrated hyperosmotic, and free water clearance is negative, meaning the body is retaining free water. When ADH is low, or in central diabetes insipidus, the collecting duct stays water impermeable, the urine is dilute hyposmotic, and free water clearance is positive. The body is losing free water. The correct answer is E. The free water itself is generated by the thick ascending limb of the loop of Henle, an early distal tubule, the diluting segment, which actively reabsorbs NACO without water. It is water impermeable, leaving behind dilute tubular fluid. Whether that free water is then excreted, positive clearance, or reabsorbed in the collecting duct depends on ADH. So SI8H gives a strongly negative free water clearance, water retention, hyponatremia. DI gives a positive one, water loss. The ADH-dependent sign of free water clearance, generated by the thick ascending limb, is correct. Which statement about macrolides is correct? A patient with community-acquired atypical pneumonia is treated with azithromycin. Another with a penicillin allergy takes erythromycin. Read the command. Which macrolide statement is correct? Bind 50S, block translocation, bacteriostatic, atypicals, streptopertussis. Streptopertussis, QT prolongation, motulin agonist, erythromycin, CYP450 inhibition. Macrolides, azithromycin, clarithromycin, erythromycin, inhibit protein synthesis by binding the 50S ribosomal subunit and blocking trans. Location of the ribosomycin. They are generally bacteriostatic. Their spectrum makes them first line for atypical pneumonia, mycoplasma, legionella, chlamydia, and they cover streptococcus useful in penicillin allergy, some respiratory gram-positives, bordetella, chlamydia, chlamydes, copier train gram-positives, gockerel, location of the ribosome. The correct answer is C. The toxicities are the high-yield test points, remembered as macro, motility issues. Erythromycin is a motilin receptor agonist stimulating gut motility used for gastroparesis but causes GI upset, arrhythmia, QT, prolongation. Torsades risk, acute cholestatic hepatitis, rash, and eosinophilia. There are also CYP450 inhibitors, especially erythromycin, clarithromycin, raising levels of drugs like warfarin and statins. The 50S binding bacteriostatic macrolides with QT prolongation, motulin agonism, and CYP450 inhibition is the correct statement. This question targets the complications of the disease, which complication and mechanism are shown, and what is the splenic course. A 9-year-old with known sickle cell disease presents acutely with severe bone pain, then chest pain, fever, hypoxia, and a new pulmonary infiltrate. He has a history of a prior splenic problem. Read the command. Which complication mechanism and splenic course? Sickle cell, vaso-occlusive crisis, leads to acute chest syndrome. Autosplenectomy leads to encapsulated infections. Parvovirus leads to aplastic crisis. This question revisits sickle cell disease from the complications angle. The underlying mechanism is the same. Deoxygenated HbS polymerizes sickling red cells that occlude the microvasculature. A vaso-occlusive pain crisis causes severe bone back pain, and when the sickling occludes the pulmonary microvasculature, it produces ACU chi chest syndrome, chest pain, fever, hypoxia, and a new pulmonary infiltrate. Acute chest syndrome is a leading cause of death in sickle cell disease and is often precipitated by infection or a vaso-occlusive crisis. The correct answer is D. The splenic course is a classic theme. Early on, children can have splenic sequestration. Pooling of blood leads to shock. Over time, repeated splenic ischemic prophylaxis. Infarction leads to autosplenectomy, a small, fibrotic, non-functional spleen, which leaves the patient vulnerable to encapsulated organisms. Streptococcus pneumoniae, H. influenzae, and especially Salmonella osteomyelitis is hence vaccination, and especially Salmonella osteomyelitis is hence vaccination prophylaxis. Also remember parvovirus B19 causing an aplastic crisis, reticulocytopenia. Treat crises with hydration, oxygen, analgesia, hydroxyurea, raises HbF, prevents them. The vaso-occlusive acute chest and autosplenectomy complications define sickle cell disease. Which organism is responsible and the post-infectious complication? A 22-year-old develops bloody inflammatory diarrhea with fever and crampy abdominal pain after eating undercooked poultry. A few weeks later, he develops ascending symmetric weakness and a reflexia. Stool culture grows a comma-esh, shaped oxidase-positive, gram-negative rod that grows at 42 degrees C. Read the command, organism and post-infectious complication. Bloody diarrhea after poultry, comma shape, 42 degrees C, then ascending weakness, Campylobacter jejuni, Guillain, Barre. This is Campylobacter jejuni, one of the most common causes of bacterial gastroenteritis. It is a comma or S-shaped gullwing, oxidase-positive, gram-negative rod that is thermophilic, growing at 42 degrees C. It is acquired from undercooked poultry, unpasteurized milk, or contact with animals, and causes a bloody, inflammatory diarrhea with fever and crampy abdominal pain, which can mimic appendicitis. The correct answer is C. The high-yield post. Infectious complications are the reason it's tested. Campylobacter is the most common identifiable antecedent infection of Guillain-Barré syndrome, an acute ascending, symmetric, demyelinating polyneuropathy with areflexia. Via molecular mimicry antibodies against Campylobacter lipo, oligosaccharide cross-react with peripheral nerve gangliosides. It is also a trigger of reactive arthritis cross-react with peripheral nerve gangliosides. It is also a trigger of reactive arthritis gangrene. Treatment of the diarrhea is usually supportive, macrolides if severe. The poultry-associated, comma-shaped organism that precedes Guillain-Barré is Campylobacter jejuni. Which statement is correct? A physiologist applies the Frank-Starling relationship to a failing heart. This question targets how preload, afterload, and contractility shift the curve. Read the command. Which Frank-Starling statement is correct? SV versus preload, increased contractility shifts up left, heart failure shifts down right, increased afterload lowers SV. This revisits the Frank-Starling relationship from the heart failure curve shift angle. The Frank-Starling curve plots ST arc volume or cardiac output against preload end diastolic volume, fiber length. The intrinsic mechanism, more preload stretches the myocytes, leads to more forceful contraction, leads to greater stroke volume. But the position of the whole curve depends on contractility, the inotropic state. The correct answer is B. I increase contractility. From sympathetic stimulation, catecholamines or inotropes like digoxin shifts the curve. Up and to the left, more stroke volume for any given preload. Decrease contractility as in systolic heart failure or with beta blockers acutely shifts the curve. Down and to the right, the heart generates LES stroke volume for a given preload, so it operates at higher filling pressures, producing congestion-mined pulmonary edema. Increased afterload also lowers stroke volume. This explains why a failing heart relies on the Starling mechanism, dilation, and why reducing preload afterload helps. The contractility shifts up left and failure shifts down right behavior is correct. What is the diagnosis and the organism? A 50-year-old man has chronic diarrhea with malabsorption, steatorrhea, weight loss, migratory arthralgias, and neurologic and cardiac symptoms. Small bowel biopsy shows the lamina propria filled with PAS, positive foamy macrophages containing gram-positive rods. Read the command, diagnosis and organism. Malabsorption plus arthralgias plus neurocardiac plus positive foamy macrophages, Whipple disease, tropharema, Whipple-E. This is Whipple disease, a rare systemic infectious disease caused by tropharema, Whipple-I. A gram-positive actinomycete, the organism is taken up by macrophages in the small intestinal lamina propria where it accumulates. Producing the diagnostic histology, the lamina propria packed with foamy macrophages that are PHERs, periodic acid, Schiff and diastase, resistant, containing the rod-shaped bacteriotic acid, Schiff and diastase, Schiff and diastase. This impairs lymphatic transport and absorption. The correct answer is D. The clinical picture is multisystem, captured by the mnemonic foamy whipped cream in a can. Cardiac symptoms, arthralgias, and neurologic symptoms, on a background of malabsorptive diarrhea, steator, EA, and weight loss. It classically affects older whitmean. It is distinguished from celiac villus atrophy, anti-tissue transglutaminase, and Crohn. Treatment is prolonged antibiotics, ceftriaxone, then long-term TMP SMX. The PAS positive foamy macrophage malabsorption from Trophorema whipplei is Whipple disease. Which nerve and division explain the foot drop, and what does the sciatic nerve divide into? A patient with a deep gluteal injury or improperly placed intramuscular injection develops weakness. A second patient with a fibular neck injury has foot drop and cannot dorsiflex or evert the foot, with sensory loss over the dorsum. Rate the command. Which nerve division for foot drop? Sciatic divisions. Sciatic leads to tibial plus common peroneal. Common peroneal, fibular neck leads to dorsiflexion aversion. Injury foot drop. The sciatic nerve, L4S3, is the largest nerve in the body. In the posterior thigh, it divides into two terminal branches, the tibial nerve and the common peroneal, common fibular nerve. The common peroneal nerve is the key to foot drop. It wraps superficially around the fibular, peroneal, neck, a very exposed location, so it is commonly injured by fibular neck fractures, tight casts, or prolonged leg crossing. The correct answer is E. The functions split cleanly, remembered as PED peroneal everts and dorsiflexes, TIP tibial inverts and plantar flexes. The common peroneal nerve supplies the muscles of dorsiflexion and eversion and sensation to the dorsum of the foot lateral leg, so its injury causes foot drop. The patient can't dorsiflex, leads to a steppage gait with loss of aversion and dorsal sensory loss. The tibial nerve supplies plantar flexion and inversion and the sole, so foot drop common peroneal, not tibial or femoral. The sciatic into tibial and common peroneal division with common peroneal causing foot drop is the answer. How are personality disorders clustered? A psychiatrist classifies several patients. One is odd-eccentric and socially detached with magical thinking. One is dramatic, attention-seeking, and emotionally labile. One is anxious, perfectionistic, and preoccupied with orderliness. Read the command. How personality disorders are clustered. AU, weird, paranoid, schizoid, schizotypal. B, wild, antisocial, borderline, histrionic, narcissistic, she, worried, avoidant, dependent, OCPD. Personality disorders are enduring, pervasive, inflexible patterns of inner experience and behavior that deviate from cultural expectations, are stable over time, and cause distress or impairment, and they are typically ego-asymptotic. The person sees the trait as part of themselves, not a problem. They are grouped into three clusters, memorably weird, wild, worried. Cluster A, the weird, odd, eccentric group, paranoid, eschizoid, detached, no desire for relationships, and eschizotypal odd beliefs, magical thinking. The correct answer is D. Cluster B, the wild, dramatic, erratic group, antisocial, disregard for others' rights, borderline, unstable mood relationships, splitting, histrionic, attention-seeking, dramatic, and narcissistic grandiosity. Cluster C, the worried, anxious, fearful group, avoidant fears rejection, dependent needs to be cared for. Obelidant fears rejection, dependent needs to be cared for. And obelescence, compulsive personality disorder, rigid, perfectionistic, orderly, distinct from OCD, which has true obsessions, compulsions, and is ego-dystonic. The A weird, B wild, C worry clustering is the answer. What is the diagnosis? The Guinea protein and the feared complication. A tall young man has long extremities and fingers, arachnodactyly, a pectus deformity, hyperflexible joints, lens dislocation UP ward, and aortic root dilation at risk of dissection. It is autosomal dominant from a defect in a connective tissue glycoprotein. Read the command. Diagnosis: gene-protein complication, tall, arachnodactyly, upward lens dislocation, aortic root dilation, AD, Marfan, fibrillin 1, EFBN1, aortic dissection. This is Marfan syndrome, an autosomal dominant connective tissue disorder. The defect is in fibrillin 1, the FBN1 gene, a glycoprotein that forms the scaffold for elastic fibers, microfibrils. Defective fibrillin weakens connective tissue throughout the body and also dysregulates TGF-beta signaling. Skeletal features: tall stature with long, thin extremities, arachnodactyly, long spider-like fingers, a pectus deformity, joint hypermobility, and a high arched palate. The correct answer is A. Two findings distinguish it. The eye, UP ward superotemporal, LENs, dislocation, ectopia lentis, a useful contrast with homocystinuria, which also gives Marfanoid habitus but with downward lens dislocation, thrombosis, and intellectual disability, and is autosomal recessive. The feared complication is cardiovascular. Cystic medial degeneration of the aorta causes aortic root dilation, predisposing to aortic dissection and rupture, the major cause of death, plus mitral valve prolapse. Managed with beta blockers, ARBs, and aortic monitoring. The fibrillin 1 disorder with upward lens dislocation and aortic dissection risk is Marfan syndrome. What is the diagnosis? The Guinea protein and the mutation type versus its milder cousin. A 4-year-old boy has progressive proximal muscle weakness, a waddling gait, and uses his hands to climb up, his legs to stand Gower sign. He has enlarged pseudohypertrophic calves and a markedly elevated creatine kinase. It is X-linked. Read the command. Diagnosis: gene protein, mutation versus cousin. Boy, proximal weakness, Gower's, calf pseudohypertrophy, increased CK, X-linked, Duchenne, dystrophin frameshift, Becker in-frame, milder. This is Duchenne muscular dystrophy, DMD, an X-linked recessive disorder, so it affects boys. The defect is in the dystrophin gene, the largest gene in the genome, specifically a frameshift or nonsense mutation that produces no functional dystrophin. Dystrophin anchors the muscle cytoskeleton, acting to the extracellular matrix. Without it, muscle fibers are damaged with each contraction and progressively degenerate, replaced by fat and fibrosis. The correct answer is B. The clinical clues are classic: onset before age 5, with proximal muscle weakness, pelvic girdle first, a waddling gait, the Gower sign using the arms to walk up, the legs to stand, and calf PSC hypertrophy, enlarged from fat fibers replacement. Creating, kinesis is markedly elevated. Progression leads to wheelchair dependence and dilate, cardiomyopathy, respiratory failure. The key contrast is Becker muscular dystrophy, a non-frameshift in-frame mutation that yields partially functional, truncated dystrophin, so it is milder with later onset. The absent dystrophin frameshift X-linked dystrophy with Gower sign is Duchenne. Which statement about cochlear auditory physiology is correct? A physiologist studies how the cochlea converts sound into neural signals and encodes pitch. Read the command. Which cochlear statement is correct? Organ of Corti transducers, tonotopic, bassy high frequency, apex low frequency, hair cell stereocilia, leads to K+, leads to depolarize, leads to CN8. In the cochlea, sound waves vibrate the basilar membrane and the organ of Corti, sitting on it with its sensory hair cells, transduces that mechanical vibration into a neural signal. The cochlea is synotopically organized, meaning different locations along its length respond to different frequencies based on the mechanical properties of the basilar membrane. The correct answer is E. The frequency map is the high-yield fact. The BAAC of the cochlea near the oval window is narrow and stiff, so it resonates with hitch-frequency high-pitched sounds. The apex is wide and floppy, so it responds to low-frequency low-pitched sounds. Mechanistically, basilar membrane movement deflects the hair cell. Stereocilia Opening mechanically gated K plus channels. K plus from the high K plus endolymph flows in and depolarizes the hair cell, releasing neurotransmitter onto the cochlea CNV8 nerve. This is why noise-induced and high-frequency hearing loss damages the base first. The tonotopic base higher apex low organ of chordy transduction is correct. Which set of findings defines symptomatic multiple myeloma? A 68-year-old with known multiple myeloma is evaluated. This question targets the diagnostic features and labs. Read the command. Which findings define symptomatic multiple myeloma? CRAB, hypercalcemia, renal, anemia, bone lesions, M-spike, Bence-Jones, rouleau, clonal plasma cells. This revisits multiple myeloma from the diagnostic features angle. Myeloma is a malignant proliferation of clonal plasma CELS in the bone marrow producing a monoclonal immunoglobulin. The end organ damage is summarized by CRAB, hypercalcemia from bone resorption, confusion, constipation, stones, renal, insufficiency, light chain, myeloma, cast nephropathy, anemia, marrow replacement, fatigue, and bone lytic lesions, punched out lesions, pathologic fractures, and backbone pain. Correct answer is B. The LAB hallmarks confirm it. Serum protein electrophoresis shows a monoclonal M spike, usually IgG or EGA. The urine contains Bence-Jones proteins, free monoclonal light chains, which the SPEP may miss. The peripheral smear shows Rouleau formation urec stacked like coins from the high protein, and the marrow shows 20 place. Cells with clop face, chromatin. Distinguished from MGUS, asymptomatic, no CRAB, and Waldenstrom, IgM. The CRAB end organ damage plus M spike, Bence-Jones, and Rouleau defines symptomatic multiple myeloma. Which statement is correct? A patient is started on metoprolol after a myocardial infarction. Another takes propranolol for performance anxiety. A third with asthma is cautioned against non-selective agents. This question targets the USES and toxicity of beta blockers. Read the command. Which beta blocker statement is correct? Decreased HR contractility, AV renin, uses HTN in a post, miss MIHF arrhythmia, cautions bronchospasm, bradycardia masking hypoglycemia, overdose glucagon. This revisits beta blockers from the clinical uses and toxicity angle. By blocking beta-1 receptors, they decrease heart rate, contractility, AV nodal conduction, and renin release, lowering cardiac workload and oxygen demand. The clinical USEs are broad, hypertension, angina reduced demand, post-MI, and chronic systolic heart failure mortality benefit. Carvedilol, metoprolol, bisoprolol, supraventricular and ventricular arrhythmias rate control, as well as essential tremor, migraine prophylaxis, performance anxiety, thyroid storm, and variceal prophylaxis. The correct answer is D. The toxicities and cautions are high yield. Non-selective agents, propranolol, can cause bronchial spasm. Avoid an asthma copti. Prefer cardioselective beta-1 agents like metoprolol if needed. They cause bradycardia and AV block. Avoid with non-DHP calcium blockers, fatigue, septal dysfunction, and can mask the adrenergic warning signs of hypoglycemia in diabetics. Sonsicities in talk the hypoglycemia. In diabetics, hypoglycemia. In diabetics, warning Xinian and May recovery. And acute decompensated heart failure, they're held. Overdose, bradycardia, hypotension is treated with glucagon, which raises cardiac camp independently of beta receptors. The beta blocker uses with bronchospasm, bradycardia cautions, and glucagon antidote is correct. Which Plasmodium species and what drug is added to eradicate the dormant liver stage? A traveler returns from a trip and, weeks later, has recurrent cyclical fevers, chills, and sweats with anemia. Blood smear shows ring forms and Schuffner dots. Some hepatic forms can stay dormant and cause relapsing months later. Read the command. Which species and eradication drug? Cyclical fevers, Schuffner dots. Dormant liver forms relapse. Plasmodium vivax ovale. Primaquine, check G6PD for hypnozoites. This is malaria caused by Plasmodium vivax or P. ovale. These species cause tertian, malaria, fever spikes every 48 hours, with the classic paroxysms of cold chills, then high fever, then drenching sweats, plus hemolytic anemia and splenomegaly. The smear shows ring trophozoites and in vivax ovale, the infected red cells are enlarged with SCGF near dots. Diagnosis is by blood smear, thick and thin. The correct answer is A. The high-yield distinguishing feature is the dormant liver stage. Unlike P. falciparum, P. vivax, and P. ovale form HYPinozoites, dormant forms that persist in hepatocytes and can reactivate weeks to months later, causing relapse. Standard blood stage treatment, chloroquine or ACT, does not kill hypnozoites, so you must add primaquine to eradicate the liver stage and prevent relapse, but check G6PD status first, because primaquine causes hemolysis and G6PD deficiency. P. falciparum is the severe irregular fever. No. Hypnozoite species. The relapsing Schaffner dot hypnozoite forming species. Needing primaquine is species. What is the immunodeficiency and the molecular defect? A child has recurrent severe pyogenic and fungal infections, partial oculocutaneous albinism, peripheral neuropathy, and a bleeding tendency. Neutrophils contain giant cytoplasmic granules and fail to kill ingested microbes. Read the command, immunodeficiency, and molecular defect. Recurrent infections. Pru, partial albinism, Pru, neuropathy, Prus, bleeding Prus, giant granules. Chediak, Higashi, LYST, gene, lysosomal trafficking. This is Chediak Higashi syndrome, an autosomal recessive immunodeficiency. The molecular defect is in the LYST gene, lysosomal trafficking regulator, which impairs the normal trafficking and fusion of lysosomes with phagolysome formation. As a result, neutrophils ingest microbes but cannot properly kill them, and lysosomal contents aggregate into characteristic GIAT, cytoplasmic GRAN, less visible in neutrophils and other cells. The correct answer is C. The multisystem features all flow from defective lysosome-related organelle trafficking. Recurrent pyogenic, especially staph strep and fungal eye infections, failed killing. Partial, cholecutaneous, albinism, melanosomes, lysosome-related organelles can't deliver pigment, peripheral neuropathy, and a bleeding tendency, defective platelet-dense granules. Patients are also prone to an axillary defective platelet-dense granules. Patients are also chronothy, and a bleeding tendency, defective platelet-dense gran. The mnemonic captures it: giant granules, recurrent infections, albinism, neuropathy. Contrast: CGD, NADPH oxidase, negative DHR, nitro blue tetrazolium and LAD, CD18, no pus, delayed cord separation. The LYST defect syndrome with giant granules and partial albinism is Chediak Higashi. Block 31 is done. Let's review the 5 biggest traps from this block. Trap 1. The PTT measures the intrinsic pathway. The PT and INR measure the extrinsic pathway with factor 7. Warfarin hits factor 7 first, so it prolongs the PT. Heparin works through the intrinsic side and prolongs the PTT. Trap 2. Dilated cardiomyopathy is systolic dysfunction with a low ejection fraction, the dilated weak pump. Think ABCCCD for the causes, and viral Coxsackie myocarditis in a young post-viral patient. Trap 3. Both morphin and homocystinuria give a morphinoid body, but the lens dislocates upward in morphin and downward in homocystinuria. Morphin is a fibrillin, one defect, and the killer is aortic root dissection. Trap 4. The sciatic nerve splits into tibial and common peroneal. Foot drop, loss of dorsiflexion, and eversion is the common peroneal nerve at the fibular neck. PED, peroneal everts and dorsiflexes. Trap 5. Plasmodium vivax and oval form, dormant, liver hypnozoites that cause relapse. Chloroquine clears the blood, but you must add primaquine to kill the liver stage, and check G6PD first to avoid hemolysis. 31 blocks, 620 questions. Train, process, not memorization. StepLogic, learn how to think, not memorize.